My dear students and colleagues, it's a great honor and pleasure for me to be amidst you today on a very important flagship project of Diabetes India, supported by an unrestricted educational grant from the USV, who are known for their medical education activities. Dear friends, we are going to discuss about one of the most important and most expensive complication of diabetes, that is the diabetic foot syndrome. Remember that the most important cause of amputation next to road traffic accident is the diabetic foot. And in India, in our country, most of the amputations do occur in diabetic neuropathic foot, which I'll be speaking about mostly today. And it's a shame to amputate diabetic neuropathic foot because it is eminently preventable. That is the theme of my talk today. Dear friends, the burden of diabetic foot in our country is huge. This diabetic foot is characterized by a classical triad. This triad includes neuropathy, ischemia, and infection. The reported prevalence of diabetic peripheral neuropathy ranges from 16% up to 66% in various studies. 15 to 20%, that means 1 in 5 of the diabetic foot ulcers, if untreated, will need amputation. A great malady. So this triad of neuropathy, ischemia, and infection produce what we call the ravages of diabetic foot syndrome. Dear friends, let us come first to the how do we examine a diabetic foot. Diabetic foot, I told you in India, 85% are neuropathic foot. Diabetic foot, specifically neuropathic foot or neuropathic painful foot is a preventable disease. It has been shown that in about 80% of the neuropathic foot, like diabetes, diabetic neuropathic foot is also a silent disease. Can you tell me why? I'll give the answer. It is because it's a painless foot. We always say the diabetic foot could have produced little bit of pain or fever in the neuropathic foot. Because of the neuropathy, it's an insensate foot. So it's a neuropathic silent foot, and in 80%, one does not aware about neuropathy in the feet. What should be our goal? We should identify 5 varieties, 5 grades of diabetic foot. Number 1, of course, the normal feet. Number 2, diabetic foot at risk, most important entity for preventing diabetic foot ulcer. Number 3, presence of significant neuropathy, because this insensate foot which do not feel the pain is most prone, most vulnerable to the diabetic foot ulceration. Of course, we must identify the presence of significant ischemia, lack of blood supply, which is very simple. I'll come to it in a minute. And of course, one should inspect the bottom of the feet, the dorsum of the feet for any foot lesion, which is very important. These are the facets of diabetic foot examination. Dear friends, while taking the history of the diabetic foot, please concentrate on the duration of diabetes, because neuropathy is a function of duration. Any history of tingling, numbness, or burning in the foot, very, very common. Any history of previous foot ulcer, previous amputation of a foot or a digit or whatever, and claudicating pain in the leg, which is an indication of diabetic ischemia. Difficulty in walking, that makes the feet vulnerable for the pressure points for developing ulcer. Of course, use of tobacco and smoking, which is the numero uno cause of diabetic ischemic limb. And alcoholism, because alcoholic neuropathy adds on to diabetic neuropathy and compounds it. It's not 1 plus 1 is not 1. It is 1 plus 1 is 5, 6, 7, or 8 or 9. And most important, one must also take the history of the comorbidities. As you know, diabetes is a silent disease. It's a sweet disease, but with sour company. What are the sour company? The companies are the comorbidities. So one must collect the history of hypertension, dyslipidemia, loss of vision, and the chronic kidney disease. I'll give an example. Today we call of diabetic foot and eye syndrome because vision loss is associated with particular type of diabetic foot. Today we have a syndrome called renal diabetic foot syndrome, which occurs in the diabetic kidney disease because of vasculopathy, because of dialysis keeping the foot under pressure in one position more than 3 hours. So one has to take history of these comorbidities. Very important. Dear friends, the next important aspect is a proper inspection and palpation. Diabetic foot syndrome assessment, prevention, and treatment is not a rocket science. It needs your heart, soul, mind, and body. You have to inspect the skin, the nails, any deformity. I'll come in a minute. Any callus. Callus is an overlying tissue which buries a deep ulcer. And you cannot be callous about a callus because that is the harbinger of a diabetic foot ulcer. You should be careful about inspecting for the corns, any ulceration, and watch the gait because the gait can give you the clue about the pressure points. Palpate the peripheral pulses. You cannot forget about it. Palpate dorsalis pedis and postotibial. 2 arteries are enough. Look for the bony prominences and the plantar aspect where the ulcers do occur. Look for the pitting edema. That shows the neuropathy or diabetic heart failure. Look for the temperature difference in the either feet because that gives a clue to the loss of vascular supply, claudication, and vascular feet. Look for the joint mobility because the joint do not move, that becomes stiff and becomes a pressure point of the ulcer. And we call it LMJ, limited joint mobility, and it is a harbinger of ulcer. Look for the subtalar joint position at rest and look for the heel strike at what position while he walks, the heel strikes the ground. So that becomes a beginning of an ulcer. I have brought for you an album of the various foot deformities and the foot lesions. The first one is the hammer toe. It is the hammer toe. You can see the hammer toe like a hammer. It pitches on the ground. This is the bunions on the feet. This is the very, very common interdigital mycosis. This is the callus, the hard fibrous tissue under which the ulcer is existing, and paronychia. They're the 5 very common foot lesions. There are a few others which I'll describe now. Now we have a type of advanced neuropathic foot. We call it Charcot foot. Because of the severe neuropathy, there is no pain sensation. So the bones break, there is fracture, and the entire feet becomes a bag of bone. It's called Charcot feet. A French physician described it. And there are long and deep fissures on the heel, which again are the portal of entry for the ulceration. And diabetics, if you observe carefully, in neuropathy, diabetics do develop brown circular patches on the shin of tibia, and we call it Mellin's spots. Next important issue is to examine an ulcer, a diabetic foot ulcer. My dear students and my dear colleagues, I'll urge you that we must assess the diabetic foot meticulously. The ulcer has to be assessed meticulously in 6 aspects. Number 1, the site, very important. If there's a pressure point, we have to provide, what do we have to provide? We have to take out the pressure. If you take out the pressure, the ulcer heals. That is called taking out the pressure on the diabetic foot. Number 2, the size of the ulcer. You can do it by measurement. You can do it by a mobile phone photograph. You can do it by extrons. We must look at the periphery of the ulcer. Look at the depth of the ulcer and contents of the ulcer, whether it is purulent, it is blood stain, and also look for the adjacent skin environment. Therefore, dear friends, this is the ulcer examination. Further, one has to be careful about the footwear. You cannot forget to examine the footwear. Believe me, dear friends, inside the footwear, we have found everything. Keys, nails, the wall pins. We have found everything, small wooden plaques. And because neuropathic foot cannot sense it, they stay inside the foot and produce ulcers. Therefore, we must insist on removal of the shoes and socks and have a good look at the feet. Inspect the footwear from all sides, top, bottom, behind, and sides. Look for the shoes that are worn out, that can produce terrible pressure, or the shoes that are small, can be compressing the foot. Too narrow foot sometimes the ladies put very narrow foot, narrow console, narrow front, too low or very high heels, which makes a lot of pressure on the feet. And also inspect the socks. Dear friends, the Paul Brand, who is the father of diabetic foot, in one of the last addresses was asked, what is your message to the diabetic foot surgeons? Before he passed away, his message was, examine the foot from all angles. Take out the shoes and socks yourself and inspect the foot. That will give you the clue how to treat it. The neurological examination of the diabetic foot is centered around 5 simple tests. We have made it very simple for you. I'm really very passionate about this presentation. Number 1, we have to look for the vibration perception by the 128 Hertz tuning fork. There's a 10-gram monofilament, goes by the name Sims-Winston SW monofilament, which gives a 10 gram of pressure. If you touch it and just buckle it, you must have a ankle a jerk. You must have a knee hammer to elicit the ankle jerk. You must have a pin, alpin or a safety pin to do the pin prick. And if possible, must have biosthesiometry to quantify the loss of vibration perception. We call it VPT, vibration perception threshold. If you're doing a drug trial, you know it's improving or not. If you find more than 50, the greatly insensate food. So the biosthesiometer gives you some extra information. Beyond this, dear friends, we have some tests to quantify the pressure areas of the feet. One is called MAT test. It goes by the name Harris MAT test. Now, if you walk on that particular mat, the pressure areas become very dark, very dark. It's called Harris mat. These are the pressure areas on which one can develop ulcer. This is a Charcot foot, where because of the collapse of the bone, I told you, a bag of bones, fractured bones, and because we have that, because we have that we have that bag of bones, because we have that bag of bones, you find that there is a area of the midfoot which is very dark, because the midfoot collapse of the diabetic foot. So the pressure areas, by a simple Harris, it costs 1 rupee. The paper on which the patient works is only 1 rupee, and we use the ink. It marks out the areas of high pressure, which one has to be careful in providing special food or taking special care. It's very important. Next, we come to the vascular assessment. This is about the neurological assessment. Coming to vascular assessment, the most important clue to the vascular assessment is called ankle brachial index, ABI. It is an adjunct measure to diagnose peripheral arterial disease. It is the ratio of the highest systolic blood pressure at the ankle by measuring over the dorsalis pedis artery. You can see here, he is measuring on the postotibial artery. We can measure the pressure on the dorsalis pedis artery or the postotibial artery and the systolic blood pressure in the arm. Now, if the normal ABI is between 0.9 to 1.3, if it is 0.7 to 0.9, it means there is mild ischemia, mild obstruction to the vessels. 0.4 to 0.6 is moderate obstruction. 0.4 is severe obstruction. And if you have more than 1.3, that means you are not able to compress the arteries. It's called MAC, medial arteriolar calcification. It's a sign of thickened arteries. So this is a very important test. I must tell you here one important issue. Like Women Health Initiative, today we have developed Male Health Initiative. And in a diabetic, ankle brachial ratio corresponds, I repeat again, ankle brachial ratio corresponds to coronary artery blood supply. And ankle brachial index becoming less is an indicator of the coronary artery disease. This can be done by a handheld Doppler. It's a non-invasive vascular assessment. And this is a very important test to diagnose, to quantify, and to show the ongoing monitoring of the peripheral arterial disease in the feet. Now, handheld Doppler can be performed at a very low cost and totally non-invasive. It must be done in every diabetic, but it can prevent the diabetic foot amputation. Dear friends, after the vascular assessment, we come to lab investigations. We look for the glycemia, the fasting blood glucose, PP blood glucose, HbA1c. If you have capacity to do continuous glucose monitoring, you do it. Otherwise, not a must. Look at the infections. By look for the anemia like hemoglobin, look for the CBC, total count, differential count, ESR. Always do a culture and antibiotic sensitivity. You should never forget to do for the liver function test, kidney function test, lipids, because they have a bearing, as I told you, and also examining the retina and looking at ECG, because diabetic foot, as I told you, the ankle brachial ratio related to the coronary disease. So this 5 must be done: LFT, RFT, lipid estimation, the retinal examination, and ECG. Dear friends, after doing these laboratory investigations, you must come to the infection. Diabetic foot infection is a very serious clinical problem. And mind you, we have today armamentarium of antibiotics to combat the infection if we suspect early, treat early, and eradicate early. Altered host response because of neuropathy and impaired neutrophil, the TC, total count function, are common in the poorly controlled diabetics. Properly managed, most of the infections can be cured, but many patients undergo amputation because of improper diagnosis of infection, late diagnosis of infection, or inertia. We do not give the proper antibiotic, not proper therapeutic approach to take care of infection. Presence of infection worsens the prognosis in the diabetic foot. And clinical situation can become very quickly limb-threatening because of infection. We call it limb-threatening infection, or it can be life-threatening infection when patient goes to septicemia. Dear friends, I cannot overemphasize the role of infection control in diabetic foot. Dear friends, I must tell you, what are the signs of infection? There are 8 signs: redness, erythema, warmth, you put your palm on it, in your dorsum of the foot, warmth, swelling, tenderness or pain can be, sometimes this tenderness pain is absent because of the neuropathy, because the insensitive, the peripheral nerves are affected. So the tenderness and pain may be totally absent. And it can be purulent secretion or non-purulent secretion. There's a discolored granulation to shoe because of ischemia, because of impending gangrene, and also undermining of the wound edges. And you must see there's a foul odor which says that the anaerobic organisms or the saprophytes are there in this particular foot also. So the odor also you will come to know is a great indicator of infection. Dear friends, the diabetic foot infections are classified as mild, moderate, severe. The mild infections are local infections involving only the skin, and it's quantified by the size of the infection. More than 0.5, less than 2 centimeter, like you find here, a paronychia. Moderate infection, the local infection, more than 2 centimeter, involving the deeper tissues, like an abscess, like an osteomyelitis. But the patient does not have septicemia, does not have systemic signs of inflammation, what we call SIRS, SARS. But in the severe infection, there's local infection along with signs of septicemia, as manifested by any 2 of the following: temperature more than 38 degrees centigrade, heart rate more than 90, the respiratory rate more than 20, and the PaCO2 is less than 32, more than 32, and the WBC more than 12,000 or less than 4,000. Dear friends, this indicates a severely infected diabetic foot. At each stage, we have antibiotics to be given. How to diagnose osteomyelitis? We diagnose osteomyelitis and diabetic foot by finding multiple discharging sinuses in the ulcer. Sometimes they will say bone spicules come out. Now we take a metallic probe and we probe, and you'll see the probe will sign the bone, probing up to the bone. Then the toe will appear like a sausage. And if you take X-ray of the foot, you'll find the suchistrum and the fulcrum. You'll find the osteomyelitic portion. People also take recourse to MRI, CT, and nuclear scan to diagnose osteomyelitic foot, because you have to take out the dead bone to heal it. And sometimes we cannot find it out by X-ray or by probing. You have to take recourse to MRI, CT, and the nuclear scan. And sometimes people do bone biopsy to find out the type of infection it has got. It's very important. Dear friends, I have shown you the PTB, probe to bone test, just a metallic probe the doctor is putting inside the ulcer and seeing it goes to the bone. Clinical testing include probe to bone test, PTB test, that could be performed using a sterile, a blunt metal probe. This test is easy to perform and evaluates the ability that when you contact a bone, that means you have reached a osteomyelitic ulcer. But dear friends, what is most important beyond the clinical test probe to bone is to find out the other complications. I'll come to that in a minute. It also gives you, by the imaging modalities, you can find out many other things. Like you find here a completely destroyed bone, osteomyelitic bone, totally gone bone. You can find out gas. I'll show you the next photograph, the gas in the soft tissue, like a gas gangrene or gas forming organism. You can find foreign body. As I told you, the foot is not sensing properly, so foreign bodies can enter. Unless you take out the foreign body, they also will not going to hell. MRI is suggested when one suspects soft tissue abscess or diagnosis of osteomyelitis is uncertain. I told you some time back. MRI is contraindicated. If MRI is contraindicated, then you can go on for the radionuclide bone scan, which is chromium 51 scan, taking some 99 scan, and that also gives similar information. I'll show in the next photograph. Describe to you signs of the worsening infection. Please remember, formation by bullae. I'll show a photograph shortly. Ecchymosis on the feet. Crepitus. If you find crepitus, that means gas is there. Lymphadenopathy in the inguinal region, and gas in the soft tissue. I'll repeat again at the cost of time. Bullae, ecchymosis, crepitus, lymphadenopathy, and gas in the soft tissue makes these signs of worsening infection. If there is fever with chills, delirium, anorexia, there's hemodynamic instability like tachycardia, like hypotension. There's metabolic derangement like acidosis, hyperglycemia, electrolyte imbalance, worsening uremia, and if there is a leukocytosis, elevated ESR, and some markers like C-reactive protein, etc. high, it is a worsening sign of infection. In the next slide, I have shown you the gas. I told you this is the gas in the soft tissue. There's already an arrow here. So in the gas in the soft tissue, you can see the gas in soft tissue. The gas forming organism may not be gas gangrene, but it's a serious infection. And I told you the bullae and the ecchymosis are the signs, bad prognostic signs for the diabetic foot ulcer. Be very careful. Give highest antibiotic possible. Therefore, dear friends, we risk stratify diabetic foot. Risk category 0, which is a normal plantar sensation, is a low risk. Risk category 1, there is loss of protective sense. That's called LOPS, LOPS. Loss of protective sense. Number 2, it's called moderate risk. Risk category 2, there is loss of protective sensation, either high pressure or poor circulation, or structural foot deformity, or onychomycosis. That means there is already a structural defect in the foot, like you found hammer foot, bunions, where the pressure points are there, which can produce the ulceration. It's high risk. And risk category 3, very high risk. If there is history of ulceration before, history of amputation before, is a neuropathic fracture like a Charcot foot, these are the very high risk foot. So one must always risk stratify and try to push this risk towards the normal side as much as possible. Dear friends, the management diabetic foot ulcer, I brought one composite slide. Before I close, I want to tell you the principles of management are glycemic control. You have to establish optimal glycemic control. Surgical debridement, we call it extensive decompression. You must go to the various anatomy of the feet and take out the pus everywhere by proper surgical decompression and debridement. Post-operative care of the wound by proper dressing and antibiotics, and closure of the wound at proper time, close the wound. And sometimes today, for the vascular feet, when there's obstruction of the arterial tree, we can do stenting. We can repair that by ballooning. That's called endovascular treatment. And of course, the mainstay is the antibiotic therapy. These are the factors we use while managing osteomyelitis or severe infection. We treat the neuropathy. We have drugs to neuropathy today, like gabapentin, like we have got pregabalin, we have got multiple vitamins. We also treat vasculopathy today by endovascular treatment and some other drugs available to treat the vasculopathy today. Therefore, dear friends, the glycemic control is mandatory. In ambulant patients, it can be done by intensifying the insulin therapy, or we do what's called BITS therapy. That is called bedtime insulin, daytime sulfonylurea, is a mixture therapy or only insulin therapy. In hospitalized patients, we give IV insulin with frequent glucose monitoring. Once infection is controlled, insulin can be withdrawn and one can switch over to AD. So the message I'd like to give you that is severely diabetic foot infection, admitted in the hospital, the treatment is insulin. Dear friends, I would like to emphasize here that what is most important is the preventing diabetic foot. How to prevent it? While examining the foot, you risk categorize the particular diabetic foot as category 0, no sensory neuropathy, foot is sensing properly everything, and you ask him to come back once in a year. Patient has got sensory neuropathy, patient has got tingling numbness, not able to feel the Simpson monofilament, not able to feel the, do not have proper tuning fork testing. The vibration perception threshold is very high. You call him back once in every 6 months. Patient has sensory neuropathy already established and signs of vascular disease like ankle brachial index is 0.6, 0.5, 0.4, and the patient has foot deformity, which is harbinger of diabetic foot ulcer once in every 3 months. Patient has previous ulcer, previous amputation once in every 1 to 3 months. Dear friends, there are people in our country, people everywhere in the world who have shown by proper risk stratification and concentrating on the diabetic foot, one can salvage diabetic foot. It does not need rocket science. It needs a common sense, but what is most important, a passion to save the feet. It has been said that people will pay $10,000 to amputate a foot, but people are not careful about the prevention. But please remember, the foot problems are eminently preventable. In India, there are more so because neuropathic foot is totally preventable by proper glycemic control and treatment of neuropathy and taking care of the insensate foot by proper footwear, proper socks, and do's and don'ts. Most foot problems are preventable through early identification and prompt treatment by the skilled health clinicians. Let us take the resolution today that we will not. It's called we must prevent amputation. The limb amputation must be prevented because that is very, very derogatory, very, very drastic, and the quality of life of the patients comes down drastically. Thank you very much, my dear friends, my dear colleagues, whom I love talking to today. And thank you very, very much for a patient hearing. Thank you very much. And thanks to USB for making this happen. Diabetes India, you are great. And through your portals, we're able to provide this education for our countrymen. Thank you. Thank you very much.